when insurance gets involved, it's a volume play. You've got to do more cycles for less money and try to make it up in economies of scale. And that just that sheer number of patients that need to go through. And in order to keep overhead steady, you've got to figure out how to get efficient. The one thing all clinics hate doing is prior authorizations for insurance.
Managed care is going way up in IVF. Reimbursements are going down. How do you like that? Making less money to do more work. You know who didn't like it? Ravi and Manish. They're back on the show. Another late night episode recording. Yes, I mean Dr. Ravi Gada and his business partner, Manish Chhadua. Ravi's also practicing REI and a partner at one of the largest independently owned fertility practices in the country. Manish owns and operates 249 other businesses with Ravi. Today we talk about what 70 fertility centers are doing to decrease their admin costs for this prior authorization hell, and how they've done that mostly on the medication side up to this point, now being asked to help on the med services side. They talk about changes in the payer market. They talk about changing preferences from insurance providers, why they think Organon and Follistim might be gaining so much of that market share in the last 5 or 7 years. And holy smokes, I had no idea that academic fertility centers' ratings were so bad. I'm not trying to offend you if you work for an academic fertility center. There are probably some with really good reviews. And I know that it doesn't speak to your clinical care. But gosh, I am telling you, what we discovered in this sample size of academic fertility centers is very different from a sample of privately owned practices. But if it makes you feel bad, Ravi has me read his newest 1-star review that someone left this morning in its entirety to Inside Reproductive Health's audience of 300 million people. Enjoy this conversation of me hanging out with my buddies.
The biggest challenge with insurances at fertility centers is it's a growing part of our clinics. There's a lot of paperwork and administrative burden that comes with that. Generally, reimbursements are going in the downward direction, but overhead is going up, and we're struggling to find that balance to really handling the overhead and the administrative burden that insurance companies and patients that have insurance coverage come with.
Can you tell us how much overhead is going up? Like, is it going up a couple percentage points? Is it going up a lot more than that? And over what period of time has this been happening?
Yeah, I mean, some of it's tied to insurance and the administrative burden there, right? I graduated fellowship in 2012. And when I started down here in Texas, we were probably 30% insurance, 70% self-pay. Today, Texas is probably closer to a 65% insurance state with 35% self-pay. A dramatic shift in a matter of 12, 13 years. But you have other headwinds as well, right? Salaries have gone up, inflation has gone up, cost of buying products to service IVF patients. And so in the past, historically, that was adjusted for in the self-pay patients, but increasingly that's not adjusted in the managed care market, but they still continue to go up. In fact, the trend is probably in the downward direction in the managed care market for reimbursement.
In the downward direction?
I would say stagnant or downward, yeah. Especially if you compare it to the self-pay patients or the cash patients.
So it makes sense that it would be less than them, but why is it trajecting downward, do you think?
Well, I mean, and then again, on the clinic side, and the IVF laboratory side, you're really down to probably 5 to 7 big payers that really manage a majority of the insurance patients. And with their contract renewals, they come to you and say, here's our reimbursement formulary, here's our fee schedule, and you're left with take it or leave it. You take it, great. If you don't, or you try to negotiate it, the leverage is no longer in the clinic side. I mean, there are certainly MSOs that are getting larger and larger, but even despite that, they're able to say take it or leave it, and you still have 10 other clinics in town that are willing to sign it and take the volume and play the volume game.
So where you used to, if inflation went up or if your cost of labor or supplies went up, you used to be able to raise prices because of self-pay patients. And that's no longer the case because you're being reimbursed from insurance and they're reimbursing less.
Yeah, and listen, this isn't unique to fertility. This is across the entire medical industry at large. And
But it's
I would
been
say,
that way in the medical field at large for a while. It's
and it's just new to
relatively
us.
new to us.
Yeah, it's new to us, and we're seeing it firsthand now more than we have historically, certainly at all-time highs in terms of managed care coverage today.
Manish, what the heck are you doing about this? What are you doing to make yourself useful with all this?
Well, I'm a technologist, right? So what we're trying to do is just create process and efficiencies out of what is basically wastage or, loss in the market. So, one of the biggest components of how insurance companies work and basically the rest of that side of the industry is a lot of labor, a lot of manual hours, basically putting paperwork together, creating justifications for why these more expensive treatments are required. And like he said, IVF is just kind of coming into this where it's becoming more and more of a problem. And obviously, as Ravi alluded to, labor costs are going up in the last 5 years pretty dramatically. And so what we do is, we decided probably about 5 years ago, 4 years ago, to take that problem on head on. And basically, as opposed to, hundreds of clinics, figuring out how to train individual employees to do this work, we thought, well, why don't we just become as much of the experts as efficiently as possible in tackling that, and specifically the drug side of the prior auth process.
What was the waste? You said there was a lot of waste. What was the waste?
It's mainly time sitting on the phone with PBMs, going through paperwork, digging through insurance documentation, and then pulling that information from the EMR. The other interesting thing that's kind of part of that ecosystem is that, the clinics were having to do a lot of this work, the pharmacies were having to do a lot of this work, and ultimately those prescriptions end up going to single source pharmacies. So even the pharmacies that are trying to help out and the clinics that are doing the work, it exists on the drug side, and basically they're not going to be able to fill those prescriptions anyways.
Well, and on the clinic side, the waste comes from who's doing the prior auth at the clinic. I would bet you half of the clinics that we've onboarded at CloudRx is being done, the prior auth's being done by the nurse, and half is being done by the financial team. I mean, imagine a nurse whose job is to do clinical care day to day that's now stuck on the phone or filling out paperwork a third, a quarter of her day dealing with getting a prescription through versus taking care of patients.
So I'm not sure if I'm understanding the challenges you were just describing, Manish. Can you go over that again?
Sure. I mean, so again, labor, paperwork, time on the phone. Basically, there's a lot of this type of information. And it follows the 80-20 rule, right? You have 80% of these patients that you can probably get through pretty smoothly, but 20% of these patients basically working with their insurance, the appeals process, getting through all the minutia there really is a time waste at the clinic, and definitely not what nurses and physicians and everybody at the clinic are trained to do.
So you see this going on in clinics across the board. There's 500 clinics, maybe all trying to figure it out themselves, or a whole lot of different people trying to figure it out themselves. How are you streamlining it?
Yeah, so that's another, big hurdle, right, for us to tackle. But, our approach to a lot of that is building out workflows, using robotic process automation, using AI where we can, and basically taking that process and trying to dissect it down, right? One clinic operating on, 30, 40 patients a month gets exposure to maybe 3 of this plan, 5 of this plan, 1 of this plan. And so there's a lot of diversity in what that job entails over the course of a month. Whereas for us, now we're doing, 2,000 patients a week, 8,000 patients a month. We really do get fairly keenly focused in on what particular plans need, what exactly we have to submit, how to basically do that efficiently. And for the most part, we try to do that with technology first as kind of the easiest way to scale that process.
And are you doing this for prior auths for IUIs and IVFs and things that are billed on the clinical side, or just the meds?
It's mostly on the medications. Long term, we're looking at doing the medications plus the medical benefit side. But in this first part of kind of launching this company since 2020, it's mostly on the medication side. Now we have a relationship with most of the clinics that we work with and their billers. So we work kind of hand in hand with them, but they usually get the med auth in first. But that's actually something that we just, or the medical side authorization first, but we're actually just starting in the next probably year or two to start working on the actual procedural authorizations as well.
Someone that I work closely with went through an experience with a center that I know and like a lot, but had a really hard time because she was calling the center and they were telling her to call the PBM, who was telling her to call the pharmacy, and she was just in this triangle and almost missed her cycle, and it was a nightmare for her. She was spending hours doing this. Is this
Yeah, and that's
something that would have been prevented with you all?
yeah. I mean, prevented is a too finite word or too infinite word. I'd like to say that we could definitely help now, and this is the travesty of this is typically it is the patient that's basically stuck in this whirlwind of trying to get information from their clinic, trying to get the pharmacies to be able to communicate with them to be able to get this done, as well as working through their insurance. Like I said, we spend hours doing this all the time, and we know how hard it is to do. Imagining that a patient's having to do it one or two times or going through that process on their own, that's just such a sad thought.
You said that maybe you guys are up to 65-70% covered in Dallas right now, and Texas isn't even a mandated state. So this is just by virtue of really large employers in the Dallas Fort Worth area that are offering these benefits now. Is it going up as much as it was? Like, are we going to reach a certain plateau where maybe 20% are never covered? Are we still seeing the same growth of the PBMs, or have they reached um, a and I should say the EBM, like the employer benefits managers, are they reaching a plateau? What kind of growth are we seeing?
Yeah, even in the managed care states, we are seeing them peak out at like 70, 75%. Managed care, 25, 30% is still self-pay, but where we're seeing the growth is the volume, right? So the percentage might stay the same, but as you know, the number of IVF cycles being done every year is going up. Other states that are probably hovering in the 30%, 40%, 50% ranges are going to get to 70%. So there's still going to be percentage growth across quite a bit states, right? Dallas is easy because or has such a high percentage. Houston also, I'm sure, is quite similar because we have so many large employers. But you get out into like Alabama, Mississippi, Arkansas, certain states, they're probably sub 50%, but that will grow. But the biggest growth is really just the sheer volume and number of patients. And again, this goes back to the economics. When insurance gets involved, it's a volume play. You've got to do more cycles for less money and try to make it up in economies of scale. And that just that sheer number of patients that need to go through. And in order to keep overhead steady, you've got to figure out how to get efficient. And we looked at this model 5 years ago. We thought, where can we help clinics get efficient? And I said, the one thing all clinics hate doing is prior authorizations for insurance. So why don't we do that? I mean, that's really where the genesis of CloudRx came about. And we said, hey, Manish, listen, I can assure you, if we figure out how to solve this problem, we can make patients and clinics very happy. And we've had quite a bit of growth. I mean, we have 70 plus clinics on board at CloudRx. Like Minnie said, I mean, 40,000 plus prescriptions a month are going to CloudRx. So the growth has been phenomenal. In fact, I mean, for a clinic to get signed on with CloudRx, there's a wait list right now because we have to scale ourselves in terms of just getting the number of employees in place. So it becomes economies of scale for us. And we think, to Manisha's point, I mean, now we know these plans inside and out versus a clinic who might only see a certain plan every once a week, once every other week, and then they don't realize what drugs are covered, what's not, what's the formula. I mean, there's so many nuances to this process, and we thought someone needs to become a subject matter expert in this and deliver a service at a leaner model so that it helps to save time and honestly overhead costs.
Employees in place. What's up with that, Manish? What's up with that, Mr. AI? You don't have a digital assistant doing all this stuff right now,
You
scaling
know,
this
I,
to infinity?
I don't think the employees, are ever something that we would go without, honestly. I mean, we have really sharp people. There's certain things that still you need to have the double check. You need to have some somebody that understands what the patient's going through, understands a little bit more than where AI is today. But, there'll be a point in time where most of our employees will be focused primarily on the touch aspects of it, mainly on the final approvals, and the rest of this will get fairly automated. I do believe that.
How far are we away from that? Because I called for my HVAC annual servicing, and it was about 30 seconds into it that I'm like, am I talking to a robot? And I'm thinking it would be rude to ask her if she's a robot. So I'm not quite going to ask. And then, maybe like a minute in, she says, I'm a smart digital assistant. And then so that I was like, all right, well, now I can ask. I was like, are you a robot? And she said, no, I'm not a robot. I'm a smart digital assistant, but you're not a human. No, I'm not a human. And it was like, it wasn't like there still are some gaps. And obviously in fertility, you're talking about something more sensitive than HVAC. But the point is just the competence of that technology. It was not the old credit card phone tree. You know what I mean? Where it's like, I'm sorry, I didn't quite get that. 5, 4, it's like it's not like that anymore. It's actually a competent system. Where it wasn't competent is integrating it with the rest of their workforce, because then I got a call from a human to confirm everything, and like, well, that totally negates the point. But I was pretty impressed. How close are we to that in the fertility space?
And I think we talked about this a little bit more about how fast these things are happening. And what we see as consumers or as, people in industry, and we see AI moving really fast, even in just what we're interacting under the cloak or under the table and basically everywhere else where we don't see what's going on. It is moving at a lightning speed pace. I don't think people realize it. It's not quite there yet, just like you were alluding to. We can still kind of tell, but I can almost assure you we're not very far off from not being able to tell the difference. And basically getting to the point where now these bots that you're talking to are actually talking to bots that you put in play to do different things and knock out different tasks for you. So we'll have bots talking to bots.
Yeah, the insurance bots will be talking to your bots, right?
Yeah.
Yep.
Well, and I would tell you, right? So if you dissect out healthcare in general, investigation of benefits, looking up what someone's coverage is, looking up their deductible, almost all of that is automated in-house now, not just for us, for other hub services, other companies, but getting a prior authorization done for IVF is still a very manual process, requires a lot of phone calls and looking into a plan. You can't just log into a portal for most
Why is it
insurance
so
companies and
manual?
understand it. It's on the side of the insurance company. I mean, you can have certain ones like Optum actually has a portal that is a lot easier to look up what benefit it is, but then others have no codes for ICSI, for PGT, for cryo, for all the different codes that are required for IVF that you end up having to call a plan and talk to someone.
Do you think that this will help the employer benefits management companies, like the fertility benefit carve out companies, because they have codes for all that stuff, right? Like Progeny's got codes for all of those fertility specific things where some of the traditional insurance carriers might not, right?
Yeah, I mean, they both have the codes. I do think that the fertility benefit managers, whether Maven, Progeny, Kindbody, Carrot, the big four probably in our space, they have figured out a way to help streamline that to a certain degree. So there is some benefit there. The question will be, as they continue to grow, still the traditional PBM and insurance companies are also growing at the same pace. So I don't know that they're going to replace all of the traditional models that are out there.
Now, somebody was asking me this question recently, and I could only speculate. And so I thought maybe they'll continue to grow for those reasons. But also wonder if we actually do get a federal mandate or we do see a much, much higher volume of IVF. Will the insurance companies, the traditional people, the Uniteds, the Blue Crosses, the Aetnas, will they start to want to try to get some of the market share back from those carve outs?
Yeah, it's entirely possible, but I think what we're seeing right now is more so that they try to partner with the carve outs because, listen, I do think, these carve outs are doing a much better job than even those insurance companies feel like they can do themselves right now. And fertility is such a unique space with different needs, different demands that even in, we talked about this, there's plenty of other pharmacy hubs that do this kind of work in other disease states, but it's so unique that basically it requires someone with fertility focus to really do it right.
But I think it's the opposite. I think as it scales, I mean, you follow the money, they're going to see what they're giving up and they're going to ask to bring it back in-house.
Definitely quite possible.
We got point counterpoint with the cousins here. Where do you think? All right, Manish, let's pretend that Ravi's wrong, because I like pretending that Ravi's wrong and that you're right on this, and that they're going to continue to partner with the carve outs. Do you think that it will be like one insurance company treated like United goes with Progeny, for example, and Blue Cross goes with Maven? Do you think it will, like, it'll be exclusive deals like that, or they'll each work with each other?
Before Manish answers, can I just point, in order for me to be wrong, we have to pretend. I just like that. I'm going to record this bit.
Uh-huh.
I think, and again, this is not a formal opinion, but, at the point in time when a lot of the carve outs were growing, and this was kind of a few years back, it was like there was maybe 20 of these out there in the market. I remember seeing job postings for employees to apply for XYZ employer's job, and they would list the fertility benefit that they provide in the job posting. And so the reason why I think that this might persist, and again, this is not a formal opinion, is that so long as employers are trying to recruit top talent, and employers have the say so of how exactly they market or build this product of recruiting top talent, they're going to basically try to differentiate themselves by saying, hey, we have access to the XYZ carve out benefit as opposed to a traditional benefit. And I think that'll persist for a little bit longer. You can't argue with the money argument, I don't think, because I do think that that's a pretty big factor. So there you have it.
You heard it here on Inside Reproductive Health. Manish's official, unabashed, unapologetic, certified opinion. Do all the insurance companies cover the same drugs, or do some companies cover other drugs? How does that work?
Well, most of them have a formulary. So they cover IVF drugs as an umbrella, but they have a formulary, which is essentially a preference, or to a certain degree, you could even say a mandate that it needs to be one drug or another. For example, Follistim is on formulary for United Healthcare or OptumRx. So if you're a patient who has United OptumRx, and that's who your employer has chosen for their insurance company, it's Follistim. And CVS Caremark is also Follistim. So a lot of employees that are in that have to use Follistim. That appears a little bit different. They're usually on most plans. Avidril, HCG triggers, it depends. Interestingly that you asked that question. Recently, CVS Caremark changed their formulary from Avidril to HCG. And so even your trigger shot can be determined, but it's usually a Gonal-F or Follistim formulary at the top, but as you get further down into the other drugs, it just depends.
I know that Fairing makes Menopur. I know that the way I remember Follistim versus Gonal-F is EMD Serono. You think of the letters Gonal-F, Organon, one brand name, Follistim, one brand name. That's how I remember. Who makes Avidril and the ACG triggers?
So Avidril is made at EMD, and then Pregno, which is the HCG, is made at Organon. Navaril is another HCG. It's made at Ferring. So it's still the same three drug manufacturers for those. Then antagonists, which are like Ganirelix, Cetrotide, those are made at Organon makes Ganirelix, EMD makes Cetrotide. Some generics have come into the market. But mostly you're still dealing with the three major fertility manufacturers in the United States make up 80-90% of the IVF drugs.
So those insurance companies have what did you say? It's basically a mandate, but what do they call it?
Formulary.
So is a formulary just a euphemism for a mandate, or is it sometimes not a mandate?
Well, it's a euphemism, because when it's on formulary, something may cost $100. You can get the non-formulary, but it's going to cost you $1,000. It's essentially, you have options. The second option two is a magnitude higher in price.
So some of these insurance companies have a strong preference for Follistim. Has that always been the case?
It kind of goes up and down. It's interesting. I would say if you go back 8, 7 years ago, it was maybe a more of a Gonal-F heavy market. If you look at today, I think the market has shifted and it's probably leaning Follistim. They had some big wins in the last 5 years with a couple of major. Um, so it's probably now leaning Organon Follistim, but they're
Why do you think Organon has had I'm probably asking you to speculate. Why do you think they've had those big wins in the last 5 or 7 years?
Yeah, it's a variety of things. I mean, it's hard to really pinpoint, but I mean, they do, with a lot of different things, they've been a lot more present on the market. They've been a lot more aggressive with winning plans back. I think, they realize that the managed care market helps out in the self-pay market as well. So just maybe a little bit different tact, a little bit different level of aggression in trying to win those plans over.
the other one is it wasn't always Organon. I don't know, Griff, if you remember, but probably when did that change?
6 or 8 years ago?
I think 4 or 5 maybe, but it
No,
used
it
to be
was
under
longer than
Merck.
that.
Yeah, so it used to be under Merck, but even before that, it was Organon. So it went from Organon, then it went to Merck. Merck really grew with a product called Keytruda. It's an oncology drug, and their oncology and vaccine divisions exploded. I mean, they were so ultimately, let's call it in the last 5 years, they spun off fertility and women's health to a new company. That new company, they could pick the name and choose whatever they wanted to. The nostalgia from when Organon was around, and this was probably even before my fellowship, was high on the list. So when it came back out, it came back as Organon. And it's very much a women's, it's one of the largest, if not the largest, women's health pharmaceutical company globally. And so I think spinning that off, making Organon a women's health pharmaceutical company on its own, standalone, separate from Merck, also plays some role in it. To what extent, I don't know.
Well, is that like the rule of business of do a couple things really, really well as opposed to trying to do everything, that they're in the one space so they
I
can
think so.
focus
Yeah, I
on
mean, it makes sense, right? It makes sense to the three of us, at least.
it makes sense to the three of us. That's our story. That's it. No further explanation needed. Are all clinics struggling with the same things that you guys are seeing? Are they all having the same challenges, or do you notice that some clinics really have this challenge and other ones really have a different one?
No, I think it's the same. I've gone to a handful of these advisory boards and this, that, and it's fun because you get into a room with doctors and nurses and administrators from all over the country, and everyone starts talking. And I think the 3, 4 things that percolate up to the top is insurance, managed care, dealing with that. HR has a huge problem in clinics and maintaining staff and just all the things that come with HR. And then cost and overhead. I mean, these really are almost universal. Obviously, everybody has their own little things here and there, but if you really asked everybody sit in a room and keep talking about it, it does come down back to these handful of things.
Some people do some people see the urgency more than others, though? Do you think everyone understands that we're moving to a much higher volume field of medicine and that managed care is going to take up a much larger piece of their business than it is now?
I think 2, 3 years ago, I don't know if people really where they stood on it. I think today,
Yeah, I think it's pretty prevalent. I
yeah,
mean, I think efficiency is the name of the game, optimizing your workflows, basically figuring out how to train staff faster, making them more efficient. I mean, I think, there's a handful of clinics that are maybe in their sunset phase that are just like, hey, I'm going to ride it out, and see where it goes. But I think for the most part, all of them are fairly active. The MSOs especially, name of the game is efficiency.
yeah, the big networks definitely understand this, right? You look at Pinnacle, Prelude, First Return. I mean, these guys are really pushing the growth model, which is, I think, helpful to really service the number of patients that are in this space. And interestingly, some of those large networks are some of the first people to sign up for CloudRx because they realize they've got to become more efficient. So we service a lot of MSOs.
Yeah, for them. And I wonder if that's skewing your view a little bit, Manish. Like, what about those independent wahoos out there like Dallas Fort Worth Fertility Associates?
Who are they?
They're not allowed on CloudRx, actually.
Look them up on Yahoo.
Yeah.
But our independent groups, because I've been interviewing a couple recently, and I do like that everyone doesn't have the same focus on efficiency. But some of them I worry, like, you don't have it, like, you're not paranoid enough for me, man. Like, you're not focused enough, quite enough on efficiency. And I like that they're not looking at it as numbers that they have to hit or quotas, but I just worry that they'll get steamlined or steamrolled if there's a big jump in managed care in their area. What do you think? So obviously the MSOs, they're really hyper focused on this efficiency. What about independent practices, and what about the university systems?
Well, I mean, I know I'm probably closer to that, but the individual clinics, like all things, I think it's a very heterogeneous population. Some clinics are still getting more and more efficient, scaling. Others are kind of like Manish said, might be like in a phase where they're trying to finish out their 10-year career. Academics is where it really gets interesting. And I think that the clinicians and nurses and embryologists that practice in the university settings are isolated from it because they have a huge team of coders in terms of billing coders and as well as software coders running in the background. There, some of them that are kind of private-demic might know it, but like the ones that are purely academic, I don't know that they're doing a whole lot of these processes that are happening in the background, and those it just kind of almost happens magically. Now they probably get stuck in the nuance of it's not approved, patient can't go forward. Okay, fine, call the billing office and then come back to us. That's probably one of the beauties of being practicing in academic medicine is maybe you don't have to deal with that as much and you've got an army of people, but certainly the
But the
finance
patient
team,
still does, though.
the patient still 100%, the patient still does, the finance people in the background still see it, and the patient gets caught up in that. We have had a little bit of a hard time onboarding academic university centers at cloud for these services. Interestingly, I think there's a benefit for all kinds of clinics for this, but the red tape in just contracting and outsourcing certain parts of their ecosystem is very hard. So of all the clinics that we've onboarded and the numbers that that I've shared with you before, very little is actually in the academic university setting. So they're still doing a lot of this on their own.
Well, and just one other thing to kind of touch on your earlier question is, we do this every day. I can't imagine a nurse or a clinical staff that would volunteer to want to do this job every day. So from that point of view, some people are just change averse possibly, but again, it's not something anybody I think is volunteering to do
I
outside
can't
of us.
I can't believe I've never done a little analysis on this before, but just in the last 20 seconds, I pulled up 6 different academic fertility centers, and I'm not sharing my screen, and I'm not going to. They're horrendous. They're horrendous, and these are good programs. These are the programs that everyone would know. And I'm Googling University Plus fertility center, so I'm getting the fertility centers Google My Business listing, not the entire system.
What's horrendous? What are you saying is horrendous?
Like threes,
The reviews,
2.9, 3 point.
the
Yes,
reviews.
yeah, their
Got
overall
understood.
rating, and not from small sample sizes either, but sample sizes of 50, 100, 150. That you could that just you don't. I never see that, or I shouldn't say never. Seldom see that in private practice. And if
Well,
I
it's
were to
just
click
a
on those, I bet you a lot of it is about billing stuff.
well, it just shows you how useless Google review ratings are because I'm sure these centers are excellent and it's just, this is the problem with the internet.
Well, you can see how useless reviews are because you have really good ones, Robbie. So
Exactly.
obviously something's not working out. No, they're not useless though because people aren't reviewing clinical outcomes. Like online reviews, feedback, patient experience is not SART data. It is something apart or overlapping, but it is people's overall respective of their perspective of their entire experience at that fertility clinic, and they don't like it. So the redeeming quality for them is the clinical team, right? Like when you see good things, they're talking about the nurses, they're talking about the doctors, but these things that people are giving them 1-star reviews on are like they don't answer the phone. I got this bill,
It's
nobody
their
explained.
experience, obviously not their pregnancy rates.
Yes, correct. But
This is interesting to see this
Okay.
debate from this point
Listen,
of view.
we're going to get sidetracked here for a minute, but I want you to Google the South Lake location and go and click on the newest review. It came in at 3:30 this morning. 3:30 a.m.
South Lake office, Dallas, Fort Worth, Fertility. Let me make sure
This
that
is
I get
my
the
problem with
right
the
listing. Okay,
internet.
71 Google reviews. I'm clicking on
Newest.
newest.
You can read it out loud.
This clinic is busy.
No,
But
okay, go to the next one. That was a 5-star.
yeah, that
Go to
was
the
probably
next.
all
Sorry,
right.
the one after it.
My private medical is a 1-star. My private medical info is being given to a complete stranger who used my name on a different email server. I am not getting any of the emails about what I am supposed to do in preparation for egg freezing, which means an enemy of mine is potentially attempting to sabotage. This is such a good use of our time to go on a side rail. To sabotage my opportunity to have biological children of my own. That's incredibly evil, jeopardizing me potentially being the mother of my own biological child. You're a monster, Rob.
An enemy has stolen my email and is sabotaging it, and therefore our clinic got a 1-star. I'm like, just because you can't rate the enemy. Anyways,
so if your point is that there are sometimes frivolous reviews, yes, you cannot take the credibility of any one review at face value. But you have a 4.7 rating overall. So this 1-star review of someone taking their cybersecurity issues out on you, which is great, is not supported by the body of evidence of other reviews. I mean, we've already established that the fact that you have a 4.7 means that it isn't
amazing.
It isn't valid.
I hope you're impressed that Ravi knows his reviews.
Yeah, look at that. I knew exactly what the last 2 reviews came in at.
That's how little value he thinks.
Because it pisses me off when people write these things.
Except for when it's amusing, right?
Right. But anyways, hey, listen, that bodes well for us, right? Because we want people to get good ratings and we want good experience at the patient level and at the clinic level, which is why a system like CloudRx to help really get these patients through and an insurance and not getting your prescriptions on time is where the frustrations come in. So, I mean, it's a great segue back into this whole thing about prior authorizations. And so I think it's partly why we've had a lot of success. I think it's why, honestly, the process is very onerous. We had a former nurse that is a nurse at OptumRx, and she didn't know that we were part of CloudRx. And at some point we were talking on a weekend about CloudRx, and she was like, that's you guys? That's you and Manish? And I said, yeah, I mean, that's a lot of that is from a company
we own 30 businesses, and that's one of them.
And she told me she thinks 20% of all phone calls that the fertility division takes at OptumRx is from CloudRx, calling them. 20% of all of OptumRx fertility division. She's like, they receive more calls from you than anybody else by far. And partly that's because of how arduous the process is, the phone calls, but also they know us pretty well at every single one of these insurance companies now. I mean, we can't really be ignored. And therefore, when we call, we have now account managers. We know we have relationships there. We can find out, why have you not gotten this through? What do we need to send you? I mean, it's a friendly relationship, but it's also everybody on that end is trying pretty hard to get these things through too as well. They don't really, at an individual level, they're not really trying to delay the prescription, but it is so time sensitive because you get your menstrual cycle start date, and all of a sudden a lot of things have to happen, and one of those is getting your medications on time. And so, that's the advantage of having a company that's niche, is to try to get this through fast.
So are you taking any? You said you got a waiting list. Can fertility centers still work with you, or are you making them sweat?
No. We're signing up clinics. There's a process. I mean, it's not, I wish it was just as easy to sign people up. So there's a process. There's an onboarding process. There's a lot of agreements, legal documents, because we're talking about patient information, patient files, as you know, BA agreements, this, that, you name it. So there's a whole process that when you decide, hey, we want to join and use CloudRx's services, then we have to go through all the paperwork that needs to happen, probably a 2-month onboarding process to get a clinic primed and ready. And for us, because it is not fully automated, it's not all robotics, we have to hire employees for those roles, right? We can't just bring on a clinic, especially a large volume clinic, 1,000 retrievals a year type of clinic, without really getting on helping grow on our end too to accommodate that. So we're certainly taking on clinics, we try to scale that and grow as fast as we can. I mean, the wildest, craziest things are November, December, January, it turns into a little bit of a nightmare because December flipped to January when most plans change over. For clinics, they'll all tell you, I mean, it's the highest burden month because everybody's got a new insurance plan, a new carrier, a new formulary, new design benefit. And so at CloudRx, I mean, we have rule, we really won't onboard and scale in November, December, simply to brace for January into February. And then you're back into kind of a normal cadence again. So there's a lot of nuances for that, but no, our goal is to continue growing. I mean, you look at the growth trajectory, it's been on a rocket ship the last probably 2 years. We have people calling on offices, explaining what services we offer, jumping on the pod like this, making sure people know that there's a service like this that's out there, and just but if there's a clinic that you have in mind, we'll let them jump to the front of the line.
Especially if they've got a 2.9 Google rating. They get to jump to, they're in need of help stat. Before we sign off on this, you guys are my early adopters. What's new in your tech stack, like your personal tech stack? What are you using now that you weren't 3 or 6 months ago?
I mean, listen, it's for me, it's pretty much a rolling ball. I mean, we're constantly adopting a lot of new tech. I could tell you that a good 85% of all the code that's being built at Reunite and CloudRx is all through AI. And, we just adopted Copilot as part of that solution. And it's really is amazing how fast it can move and what all it can do, and basically how clean the code is afterwards. I mean, it's geeking out a little bit, but fairly impressive.
On my side, it's interesting, ambient listening. I mean, we're getting better and better at having these ambient listening devices and recording meetings, minutes, but even I'm starting to try to play with this in the clinic side. And so ambient listening devices are really, I think, also going to be quite important. And they really do help you keep track of the action items that are needed during consultation or a meeting. So I think that's also something that we'll see a lot of over the next 12 months.
For personal use, what's each of your favorite LLM right now?
I mean, there's a risk factor for a lot of LLMs that are out there. So we stick to mainstream right now. So, I mean, we're still on ChatGPT for the most part.
ChatGPT also, have you heard of Notebook? What's it called?
Notebook AI from Google.
Notebook AI from Google. It's a
No,
podcast.
I use Claude. No.
No, it's a podcast. You can upload 4 or 5 PowerPoint presentations, 2, 3 articles, a couple of websites, and 2 people will come on and create a 30-minute podcast, completely like voice inflections, everything. You should check it out. It's pretty cool.
Well, there goes my career. It's down the toilet. And so when that does happen, though, then all of my episodes would just be hanging out with you guys because nobody will pay AI to do that. So I'm looking forward to it because it's always a blast having you guys back on. Manish, Ravi, thanks for coming back on the program.
Yeah, thanks for having us.
Thanks a lot.
Love listening to the show.
Take care, bud.
Thank you for listening to Inside Reproductive Health.